Hello, I'm Brian Denton from University of Michigan, and it's my pleasure to introduce our presentation for the work that was selected as a finalist for the IAAA competition. On behalf of my authors, co-authors, and collaborators, we're delighted to have been selected, and we're going to tell you about a project that was a cross-cutting, multidisciplinary piece of work that involved the medical professionals and analytics professionals. So first, the particular project we looked at involved looking at care for men with prostate cancer. Prostate cancer is the most common cancer among men in the United States and in many countries. And when somebody's diagnosed with prostate cancer, clinical staging is a very important first step. And accurate clinical staging is necessary to make sure that the optimal course of treatment is determined. And so part of clinical staging involves determining whether the cancer is still localized in the prostate or if it has metastasized. And imaging plays a very important role, specifically two kinds of imaging, bone scan and computed tomography or CT scan. And these are very expensive and important resources that are part of health systems that are used for a number of things, including staging men with prostate cancer. So a couple things that are very important to understand about this context is, one is that there are significant harms associated with missing a case of metastatic cancer. So there are negative health outcomes that would result in this case due to delays in chemotherapy, which would likely be the best course of treatment for patients if the cancer had metastasized. Misdiagnoses subject patients to unnecessary treatments, the most common of which is radical prostatectomy, which involves surgical removal of the prostate that could have the opportunity to cure a patient if the cancer is localized to the prostate, but would not be a course of treatment for patients who have metastatic cancer. And this kind of surgery has significant side effects for some patients and certainly would be something that a patient would want to avoid if it wasn't going to result in a better health outcome. So why do we choose this particular question in the complicated space of clinical decision making for prostate cancer? Well, at the time we started the project, this was viewed as one of the most important challenges through the Choosing Wisely campaign. Some of the reasons that were cited are that there's potentially harmful radiation exposure for patients who get imaging but may not benefit from it. There are incidental findings that occur on imaging that can require painful and sometimes risky follow-up procedures, such as a bone biopsy to investigate whether there's a bone metastasis. And this is also something that when imaging is used in ways that's not beneficial to patients, it could block access to imaging resources for other patients and lead to unnecessary increases in healthcare costs. Like many things in medicine, when you have a complicated clinical decision-making problem, there isn't always agreement, and this is one of those areas. So even major professional associations like the Urological Association in America and the European Association of Urology, among others, have diverging views on what's the best approach for imaging patients newly diagnosed with prostate cancer. So our project was served as a way to try to answer some of these important questions. And the specific context we looked at this in is the Michigan Urological Surgery Improvement Collaborative, or MUSIC for short. This is a physician-led statewide collaborative that's sponsored by Blue Cross Blue Shield of Michigan. It involves the vast majority of urologists across the state, which means that almost all patients diagnosed with prostate cancer have their data collected as part of this collaborative and have the potential to benefit from changes to care that this collaborative tries to make. And because of MUSIC, there is a complete perioperative data set for almost all men in the state with newly diagnosed prostate cancer, which made all of this possible for us to do some of the analytics work that we're talking about here. So our project had two main objectives. One was to create data analytic methods to provide clinical recommendations that urologists could use to provide care to patients in a way that weighs the benefits and the harms of radiologic imaging. And the second was to try to determine which patients should be referred for imaging and which patients could safely avoid imaging on the basis of individual risk factors. So we tried to take a precision medicine type approach to decision making that considered the individual factors that a patient has related to their risk of having metastatic cancer identified upon imaging. So with that, I'm going to turn things over to my collaborator, Celine Merdan, who's going to tell you about some of the analytics methodology that we used to try to enable this project.
Thank you, Brian. Our methodological approach consisted of multiple steps in sequence, starting from multidisciplinary problem assessment and framing to development and validation of descriptive, predictive, and prescriptive models for the detection of metastatic cancer. And in the final stage of our project, we performed model validation and post-implementation analysis of the impact for the proposed changes in music practices. To estimate the probability of a positive imaging test, we developed a multivariate logistic regression model based on several patient covariates, such as patient demographics, patient's prostate-specific antigen, shortly PSA level. PSA is a simple blood test that indicates the amount of the protein prostate-specific antigen that escapes into the blood from the prostate, and higher PSA levels indicate higher risk of prostate cancer. Patient's clinical tumor stage, which is a variable indicating the extent of the disease. And we also included the biopsy data that we collected from patients' pathology reports. To assess the accuracy of the predictive models that we developed, we performed both internal and external validation. The performance of the predictive models is usually better on the data sets on which these models were constructed upon versus the performance of the same model on new data sets. Therefore, validating a predictive model using the development sample will introduce bias, which is known as optimism. To address this bias in our project, we used bootstrapping resampling technique. Furthermore, we performed external validation to assess the validity of our models in new data sets that were not available to us during the initial model building process. In addition to the published clinical guidelines that my colleague Brian presented you earlier, we developed imaging guidelines using machine learning models. However, we faced two important challenges in using the observational data we had from music for classification modeling purposes. And these challenges were learning from unlabeled data and learning from imbalanced data. We had the problem of unlabeled data because in practice, not all patients receive an imaging test at diagnosis. Patients who seem to be at higher risk are more likely to be offered a test, whereas patients at low risk are less likely. We had the issue of imbalanced data because only a minority of patients has metastatic cancer. And if we don't correct for imbalanced data, machine learning models will be more inclined to miss those patients with metastatic cancer. To address these challenges, we studied two machine learning paradigms, namely semi-supervised learning and cost-sensitive learning. Semi-supervised learning is concerned with extracting information from unlabeled data, and cost-sensitive learning is concerned about finding the cost function that's going to provide us the optimal trade-off between different misclassifications. To handle these two challenges in the same framework simultaneously, we proposed a novel framework which we refer to as cost-sensitive Laplacian kernel logistic regression model. It's the spectral clustering-based semi-supervised learning approach, which starts with constructing a weighted graph, and its vertices correspond to all patients. And the way to construct this graph is as follows. If patient I is among the k nearest neighbors of patient J, then we connect these two patients with an edge and assign a non-negative weight to this edge based on the similarity measure that we calculated between these two. And we populate these weights, and later these weights are used to calculate the Laplacian metrics for our weighted graph. And here on this slide, we are looking at the nonlinear optimization problem that we needed to solve to find the optimal classification rule from our novel framework that's represented by F star here. There are three main components in this function. The first main component, which is also referred to as loss function, introduces a higher cost on misclassifying patients with metastatic cancers. This is coming from the cost-sensitive learning. The second component introduces a regularization parameter to avoid overfitting. And the third component, which is coming from semi-supervised learning, is used to extract information from patients who didn't receive imaging at diagnosis. And here on this slide, we would like to demonstrate you that we can obtain more accurate classification rules via this novel framework. On the left-hand side, we are looking at the case where misclassifying positive and negative cases have equal weights. And on the right-hand side, we are looking at the case where misclassifying a metastatic cancer patient has a higher penalty. And we can see that as we increase the penalty on missing metastatic cancers, we are detecting more patients with metastatic cancer. However, we are also mislabeling many patients with negative tests as positive. So this framework offers us to perform trade-off analysis by introducing different weights for different misclassifications. In addition to the Laplacian framework that we proposed, we also considered alternative classification models for comparison. And these classification models we adapted for imbalanced data learning, including cost-sensitive logistic regression and support vector machines, also random forest and ADABUS that we combine with advanced resampling techniques. However, as we mentioned earlier, not all patients receive an imaging test. Higher patients are more likely, lower risk patients are less likely. So if you were to evaluate the accuracy of the imaging guidelines that we generated from machine learning models or the published imaging guidelines, this would mildly increase the apparent sensitivity of the imaging guidelines and reduce the apparent specificity of the guidelines. This is known as verification bias. And to correct for verification bias in our project, we used a well-established statistical method proposed by Beg and Greenies, in which we used the logistic regression models we developed and validated early on in our project to adjust the sensitivity and specificity of the guidelines using the entire patient cohort. So here in the formulas, the components highlighted in blue are calculated using the entire cohort. The main assumption in this framework is that risk factors considered by the guidelines are the only factors that have an influence on imaging decisions, which is a reasonable assumption in our context because the music data repository included all the patient covariates that are associated with prostate cancer risk. And I will leave it up to my colleague Christine to walk you through some of the important results from our project.
Thank you, Celine. So picking up where she left off, we found that verification bias greatly impacts the apparent performance of imaging guidelines. So in this table, we're showing the uncorrected and bias-corrected sensitivity and specificity for the published clinical guidelines for bone scan and CT scan. If we look at the AUA guideline, for example, we see that the sensitivity decreased from 97.9 to 81.2, and the specificity increased from 43.5 to 82. On these figures, we're showing the bias-corrected specificity along the x-axis and the bias-corrected sensitivity along the y-axis. And on the left-hand side, we're showing the bone scan guidelines, and on the right-hand side, we're showing the CT scan guidelines. Each one of these data points represents a different guideline that we evaluated, and the blue points are showing the dominated guidelines, and the green points are showing the non-dominated guidelines. The red points are the published clinical guidelines, and you can see that they perform really well, and they're all near Pareto optimal, meaning that there's no other guideline that has a higher sensitivity and specificity. Based on these results, Music was interested in understanding the impact of the AUA recommendations if they were implemented in Music. So on the left-hand side, we're showing the impact if the bone scan was implemented, and then on the right-hand side for CT scan. We found that about 20% of patients would receive a bone scan, whereas previously about 27% of patients were receiving bone scans. And of those, 17% would be positive, which is an increase from the previous 12%. We also found that about 0.8% of patients would have missed metastatic disease, which was below music's goal of being under 1%. Additionally, about 38% of negative scans would be avoided. We saw similar findings for CT scan. These findings suggest that we can reduce healthcare costs and the burden to patient without having a negative impact on patient outcomes. Based on those results, Music implemented the Music Imaging Appropriateness Criteria across the state of Michigan, with a statewide goal of performing imaging in 95% of patients that meet the criteria and in less than 10% of patients that do not. This allows for some clinical judgment by the urologist, so there might be a patient who doesn't meet this criteria, but they have bone pain, so they might still be a good candidate for a bone scan. Music members were provided with a toolkit, including placards with the criteria, shown on the right of the screen, as well as explanations for patients. There were also several music-wide meetings where representatives from each urology practice came together to discuss the criteria as well as the goals of the collaborative. After implementation, Music achieved a statewide improvement in the utilization of imaging tests. So on this figure, we're showing the imaging rates among patients not fitting the criteria for bone scan and CT scan, and you can see for both that after implementation, the imaging rates drop below that target of 10%. Now I'd like to introduce Dr. James Monti, who is Professor Emeritus of Urology at the University of Michigan. He's the former chairman of the Department of Urology and the inaugural co-director of Music. He's going to say a few words about the impact of our work.
Thank you very much, Christine. It's a privilege to be able to participate. I would like to emphasize a couple different points. One is that Music is a population-based registry, so that our quality improvement activities essentially impacts all the patients with prostate cancer in the state of Michigan. The second point is that urologists often ordered imaging because they were afraid to miss someone who might have metastatic cancer. And so it was very important that we educate the urologists in the state with data from our own state that would show that it was safe to avoid imaging in the vast majority of patients. The improvement rates that we saw in utilization of imaging in the state of Michigan are the best that have been seen in the entire country. And so the impact of this work is quite substantial. I'd like to turn it back to my colleague, Brian Denton.
Thank you, Dr. Monti. So now on behalf of my collaborators, I'm happy to wrap up the presentation with a few key takeaway messages. First of all, as you've seen, this project involves a combination of descriptive, predictive, and prescriptive analytics that made some of this work possible. And there are a number of exciting outcomes. There's a sustained multi-year quality of life improvement among the roughly 5,000 patients per year seen in Music practices across the state of Michigan. There was a cost savings of more than $262,000 annually in direct savings associated with the reduction of unnecessary imaging, and additional cost savings related to reduction in unnecessary procedures that might follow on from that imaging. Finally, we published this work to make it publicly available both in the medical literature and in a recent paper that appeared in the journal Operations Research, so other people could use these approaches in other contexts, which we feel is a very important part of the project. So these are some of the publications that came out of this. We want to acknowledge all of our co-authors and everybody in the Music Collaborative that was involved in making this project possible with the support of Blue Cross Blue Shield of Michigan. Thank you.